meeting off today. I'd like to begin by acknowledging the Wurundjeri people of the Kulin Nations, the traditional custodians on the land on which we are based, and I wish to pay my respects to elders past, present and emerging. It is with great pleasure today that I have the opportunity to introduce Professor Maarten IJzerman to present for us today here at the Centre Seminar. Maarten would be known to most of you, I'm sure. He had been with us on level 10 for quite some time, has recently ascended to the 13th floor. But Maarten holds a number of important roles at the university. He's clearly a VCCC professor. He is the head of Cancer Health Services Research at the University of Melbourne, and indeed he is a member of both our Centre for Cancer Research and the Centre for Health Policy. Maarten is going to be presenting today. He's been quite tricky. I noticed that he's actually changed the title compared to what I originally had on the original mail out, but you managed not to catch me out this time. But the title of today's talk will be the opportunities for data-driven health services research. And with that, I'll hand over to you, Maarten.
Great, thank you very much, Sean. I'm not sure if I changed the title, but anyway, I thought for today I'll give a bit of an overview talk about the work that we've been doing in our group within the centre. And so that's one of the reasons for taking a more general title for my talk. Okay, I'd like to take you back maybe 2 years when I landed in Australia. These were the good times when Qantas was still flying in May 2018, so that's 2 years ago. And I arrived at level 10 with the UMCCR, great support from all the staff at the UMCCR and all the people there. But of course, you start building a group, and I'm really pleased, and that's what I wanted to start with, to introduce you to an amazing group of people that has grown over the last 2 years. So in May 2019, we've got 6 people with the hardcore people, so Marty, Olivia, Amanda, Fanny there, and Rob and myself. But that's grown a bit to a few more people in 2019, September 19, and a very recent picture in February 2020. And at the moment, so this is just before lockdown, and at the moment we actually work with even a bigger group of about 16 people in our centre. And it's really an amazing group of people, very multidisciplinary and very much engaged with all the work and committed to improving cancer outcomes across the board. So I'm really pleased with this group. All right, so just to give a bit of a start with a definition, because maybe you're not familiar to health service research and the definitions that are associated with that. I thought, well, I'll give you one definition of health service research to give a bit of an overview of how broad the discipline is. So this is a multidisciplinary field of inquiry, both basic and applied, that examines access to and the use, cost, quality, delivery, organization, financing and outcomes of healthcare services to produce new knowledge about structure, processes and effects of health services on individuals and populations. So that's quite broad. And you could easily say everything is health service research. So that doesn't probably make sense if you're starting a new program, building a new program. So you have to narrow that down. You have to focus to what you want to do and where you want to make a difference. So in the first couple of months, I've been really talking to quite a few people. I've had the opportunity to do quite a few presentations about the work that I was planning to do. But that came together in what I call the magic whiteboard. The magic whiteboard, and those of you that visited me, was at level 10 at that small, noisy office at level 10. There was a very interesting magic whiteboard that I used to make notes and define what I should be doing in the next years. And this is a picture that I found from that period. So this is September 2018. With the first plan for the Cancer Health Service Research Group to be developed. So as you see, very interestingly, on top, risk stratified health services. So I'm not going to talk about health services across the board. It's really about precision medicine, precision health, or risk stratification. But then the other thing is very interesting. There's three lines of research that I thought would be interesting to look into. One, very clearly health economics of whole genome sequencing and liquid biopsy, which I had a bit of experience in way back in the Netherlands. The second one, really key, is clinical registries. So use of clinical registries to map real world patterns of care. And then finally, something which we would say this is more really health services research. And I've said that's going to be risk stratified follow-up. And in all three lines of research, we have some project going on. And that's actually my talk for today. I'm going to go to all three topics, starting with the use of clinical registries to drive precision oncology. That's a big program of work. Then I'm going to talk about translating genomics into health services. And then finally, have a few slides about using linked data to improve access to cancer services. And that's pretty much based on the work that we've done in COVID-19 and delays in access to care. But before I start, I thought maybe give a bit of an overview of the different data sources that we can use. So this is data-driven health service research. That means that we do need data, different data sets to work with. And there's different levels of data sets that you can access. So we've got population level national data sets, Australia-wide data sets here. For instance, MBS, PBS items, the medical benefits scheme and the pharmaceutical benefits scheme, that's population level national data sets for health service research. Cancer registry, death registry, that's all population level national data sets. Usually very great coverage. It covers the whole of Australia, but the granularity, the depth of that data set is just limited. Because if you want to go to more clinical research, more granularity in your data, you have to go to hospital data sets here on top, on the bottom here. And we have been able to access different data sets, not yet the EMR, but that's the Parkville. I'm very keen on having that up and running so we can extract data from the EMR for health service research. But we've been prioritizing clinical registries mainly. So we've been working on different tumor stream specific cancer registries, the TRACK registry, EPAT, MRV, the tragic malignancy cohort, and PURPLE for pancreatic cancer. That's the 5 registries that we do have access to and that we've used. We've also used and be able to link genomics and pharmacy data sets. So for instance, Cancer 2015, that's an ongoing discussion with Stephen Fox and the team about getting access to panel data from Cancer 2015. So all of you probably have heard about the VCCC data set and the data hub, which is somewhere here. So the data hub is really to link different data sets together for health service research. And it's mainly at the state level data set, administrative data, VAAD, for instance, VEND, primary care data, which also has national level, but we actually try to link it at the state level. So that's the data hub, the VCCC data hub, linking clinical registries to administrative data and to primary care data. So that's where the data hub fits. So in Australia, there's not a lot of experience and there's not a lot of examples of national population level data studies because it's not easy to get population level data at a national level. But one example, this is from the Netherlands to give you an idea of what you could do with population level national data, is on treatment delays and the time to treatment initiation in the hospital. And the idea is here that you can map the treatment delays and you can specifically look into the time from diagnosis in hospital to start of the treatment. And that's one of the specific questions that we've asked or we addressed with hospital level data. So we were able to get hospital level data across the board, across the Netherlands. So there's about 79 hospitals in the Netherlands, 4,000 patients that we received all their data of the diagnosis state, the date of diagnosis and the start of the treatment. And we were able to map the delays or the time to treatment initiation. And at that time, we thought this would really depend on the type of treatment. So radiotherapy probably would take a bit more time to actually commence the treatment compared to chemotherapy. So there might be some clinical reasons for having the delays in treatment initiation. But there might also be hospital organizational factors. So so this is on the top, you see the delays, the difference between hospitals. But you can also benchmark hospitals, which is here on the lower part of the slide, where there's the average, and you can clearly see here there's a midpoint above which quite a few hospitals are above the average in terms of time to treatment initiation. And this is all corrected for case mix and for treatments that were commenced with those patients. So this probably is related to hospital organizational factors. So there might be all kinds of performance issues within the hospital that explain delays in start of treatment. So this is really national level performance of hospital, benchmark of hospital in terms of time to treatment initiation. The work that we've done in Victoria, then there's one specific project that's also using a population level data within Victoria, is mapping clinical trials. And this is a project that was performed by Nancy. And Nancy was a Master of Public Health working with us. And she was involved in a project with the VCCC on clinical trial participation in Victoria, because the key interest here is we want to make sure, and I'm citing Mike Rosenthal, he also said clinical trial medicine is good medicine. So we want to make sure that everyone has an opportunity to participate in clinical trials. And we try to map participation in Victoria with the assumption that people in metropolitan Melbourne are more likely to participate in trials. So in this case, Nancy has been able to link the clinical trial management system. So we've got a registry with all clinical trials in Victoria, in the VCCC area, and with the numbers and the postcode, so we can identify where they come from, and we can map it to the cancer incidence per postcode. So we've got postcode specific cancer incidence rates, and we can map the participation rate for each individual postcode. So that's what you can do. This is Victoria, and on the left one you see this is all tumor streams, participation rates, and this is just an example for hematology cancer, for blood cancers participation. So you see there's a few hotspots where there's more participation in clinical trials. The darker blue, it's 18% and more participation of all cancer patients in that specific postcode have participated. But you also see there's quite a few postcode areas that are not really well representative in clinical trials. So that's a concern for the VCCC, the clinical trials program, the teletrials program, but also for the department. So you can use the same type of data to also determine whether we could figure out what the values of a new trial. That's another part of the project with the VCCC. Whether we could, that's mainly a question from clinical trials units, whether we can prioritize trials in terms of funding, in terms of support. So can we manage a portfolio of trials? And that means that we probably want to fund trials that have huge value for society. And to my opinion, a clinical trial value is not the same as a statistical value. It's not the same as a p-value. The clinical trial value is a combination of different metrics that we're interested in. And this is really the work of peers in our group with the VCCC steering committee, clinical trial steering committee. So what peers did really was to figure out first, what are the metrics that determine clinical trial value? And that's not just a statistical value, but it's about unmet need. It's about the eligibility. Can all patients participate in a trial? And that really addresses the rurality or metropolitan area. Total trial cost is a metric. How you use the results, is it just to inform a new treatment being listed on the PBS, or is it informing the next stage of research, stage 1 to stage 2, for instance? Size of the target population, patient outcomes, and academic impact, the numbers of papers in high impact journals. So those metrics were identified with stakeholders, with the metric steering committee, and we can quantify those metrics in terms of weights. We can attach weights to them. How important are those weights in terms of the clinical trial value? And just for illustration, there's just 5 trials that we used. So this is an app. You can access this on the web. so this is the 5 trials that we just, as a demonstration, evaluated for those different metrics. And then you can, based on those metrics, come up with the overall value of the trial. So clearly those 2, pancreatic cancer, because unmet need is a very heavy weight in the overall value of the trial. In terms of the overall trial value score, outperform the other trials in terms of that total trial value. So that's basically how it works. And to come back to that participation rate, what Nancy did. So here you can put a weight on how important do you think that everyone in Victoria can participate in the trial. So here it's got a relative weight of 0.61, but you can change it. So you can change it to 100%, and that might change the overall trial value. So if your trial is more able to enroll patients from rural areas, it will probably increase the total trial value, and it might make a case for funding that trial or support that trial. All right, so that's the some of the work that we've done within Victoria at the population level. For the rest of my talk today, I'm really focusing on the hospital-specific data sets, clinical registries particularly. And you all know the work, because we've presented this a few times already, the work that Koen has been doing since 2018 in our group on dynamic treatment sequencing. This is based on the TREC data set, the metastatic colorectal cancer patients, a data set which is hosted by or developed by Peter Gibbs, and we were able to retrieve data through the BioGrid platform. And we can map the treatment sequences here, so 1st line, 2nd line, 3rd line treatment, and you can identify the unique combinations here and the total numbers of patients that were actually receiving 1st, 2nd, and 3rd line treatments. So that's all familiar, I think, to most of you. But before that, and I think that's really where the expertise of Fanny comes in. Fanny is really a data scientist working with us for 2 years now, where she actually has developed a very unique skill set in mapping those treatment pathways. So she's using the not the colorectal cancer, but she's really working on the lung cancer cohort at Peter Mac and the melanoma research Victoria cohort. So basically, both of them are Microsoft Access databases here, and those databases have to be processed through. All the people in our group love RStudio. I have no idea how to work with RStudio. That's for them to do. But in Access, they've got different tables with different procedures. So they've got a table of surgery, table of radiotherapy procedures, for drug treatment tables, all different tables that are relational and linked to one unique identifier. So Fanny has developed the skills and the analytic process and the R code to map those treatment pathways in terms of when can we identify the date of diagnosis from those data sets? Can we then define the first event, which is a surgical procedure, second event with radiotherapy, and then also different lines of treatments based on those different data sets. So mapping those individual data sets, large cohorts, into those timelines, that's critical for all the work that we do. So one example of the work that Fanny's been doing is on lung cancer. So she's been doing some work with Ben Solomon and David Marlise and Anne Officer, leading the thoracic malignancy cohort, comparing. So this is really mapping patterns of care, comparing smokers and non-smokers in treatment sequencing. So this is really about drug treatments, 1st, 2nd, and 3rd line drug treatment for comparing smokers and non-smokers, where there's a very interesting difference in the numbers of targeted treatments, because in particular in smokers, they usually indicate chemotherapy because there's not a lot of actionable mutations in smoker populations compared to non-smokers. So the amount of targeted treatments in the non-smoker populations is way more than in the smoker population. But the immunotherapy might be more eligible, or the smoker patient might be more eligible for immunotherapy in the later lines of treatment. So you see difference in drug treatments between smokers and non-smokers. You can also map it in terms of overall survival and the numbers of treatments lines are received. So this is the overall survival, which is based on that thoracic malignancy cohort where obviously that's not a surprise. Non-smokers have a better life expectancy than the smoker population diagnosed at stage 4 lung cancer. But what's interesting in terms of disparities in eligibility for treatments, so most of the patients, either smoker or non-smoker, receive first-line treatment. Most of them receive a second line, but then there really will be a drop. There's really a change after the third line. We see that the smoker population, there's definitely less opportunities for third, fourth, and fifth line of treatment compared to the smoker because of the targeted treatments that are not so frequently possible. So that's also kind of, there's a survival difference, but there's also not so many treatment opportunities in this smoker population. This is just mapping patterns of care. The other use of that data sets for us is really the use of real world data for we call health technology assessment. So that's really informing regulatory decision on PBS listing of new drugs or listing of new diagnostic procedures on the MBS. And one of the big reasons, and that's just, it's not just in Australia, but this is across the board, across the world, that many HTA decisions are based on clinical trial evidence. And there are some issues with that because clinical trials are not really designed to inform that process because they usually have a very short follow-up. So one of the reasons for using real-world data is to extrapolate survival in an economic model that informs that reimbursement decision. So this short follow-up, and you can see it here on this figure, where the real data, the trial data, is in the gray shaded area. So that's the dotted line, the black dotted line, and the solid here. That's the real data from the trial. So you see the average follow-up is less than 2 years within that trial. But for an economic evaluation, you want to extrapolate beyond the 2 years. And there's different ways you can do that. So you can model that survival over the course of the next 5 years. And you can see with this different modeling approaches that there's quite a significant heterogeneity between them in terms of the extrapolation of survival. So that's really concerning in terms of the uncertainty that comes with that extrapolation. So this is one specific reason for using real-world data. Can we use real-world data to inform that extrapolation beyond the trial duration? And this is not a theoretical problem, this is a real problem, and particularly also with the new curative treatments, CAR-T, which potentially have a life extending benefit that we can't measure in clinical trials. So we have to extrapolate. We don't know how to do it with curative treatments. That's critical for HTA decisions. Then the second piece is we also want to know what the real world outcomes are of those studies. So the trial evidence, and there's some different papers on that. Trial evidence is a very restricted population, but it's not representative of the whole population in the real world. So we want to know what the actual outcomes of those treatments are in the real world if we use it in a larger population. So that's the second thing for using real world data to maybe to do matching, propensity score matching within your cohort, within your registry to figure out what's the evidence of that specific treatment in the real world. But also, and that's what you see more often, I think this is a paper, just recent paper about the issue of non-randomized studies used for market approval based on EMA and FDA evidence. And I think there's up to 50 to 20% of the regulatory approvals are not based on an RCT because it's mainly just a single arm trial because it's not possible to do an RCT. So one of the things that we are exploring is where we could use registry data, real world data to develop a synthetic control arm for as a match control to the single arm trials. So that's a very specific methodological exercise that we are exploring at the moment. And then finally, I think that's the key interest that we, at the moment of approval, a new drug, you don't know how this drug is going to be used in the real world. So that's where you have an interest, the real world use of specific treatments. For instance, in what sequences, treatment sequencing, what's the best sequence of a drug? So last Friday, we had this seminar about drug treatment sequencing and melanoma with discussions about MEK BRAF inhibitors compared to immunotherapy, what the optimal sequence would be. So that's a very specific question where we can use real world data. So what's the optimal treatment sequencing? Can we come up with a method to figure out where we could optimize the best treatment sequence? And then secondly and thirdly, here the percentage of eligible patients. So that's a really uncertain area for regulatory decision makers, is that if you approve a drug, you don't know how many patients actually will use that drug. So you can't estimate the budget impact of that specific approval. So if you list that new drug on the PBS, you really want to know what's the budget implication, what's the consequence for the PBS, for the federal government in making that listing available. And that's very hard to predict based on trial evidence, because you don't know the next uptake of those drugs. And that's across the board, but that's a very specific problem in what we call the histology independent drugs. So pan-cancer drugs, for instance, entrectinib or larotrectinib, for targeting NTRK fusions. So that's a very specific issue to address, and that's something we would like to talk about as part of the new MRFF project that we were awarded about a month ago. Let's first talk about drug treatment sequencing, and I know we've got quite some discussions on drug treatment sequencing, whether we really can use registry trials or registry data to inform optimal treatment sequencing, or whether you really need an adaptive randomized controlled trials. I think we all are aware and conscious that there are significant biases in registry data, but at least we can look into the optimal treatment sequencing. We can quantify the treatment sequences, and we can do the costs of the sequence, because that's from a health economic point of view, that's very interesting. If one treatment sequence would be much more expensive than the other sequence, that might be a case. Then we might want to have a discussion whether that specific treatment sequences is worth the money. So the outcomes do outweigh the cost. But if there's not really a difference in the total cost of the treatment sequence, whether you take, in this case for prostate cancer, enzalutamide in the first line or in the second line, if the total cost of that treatment sequence is not too different, you better take the best drug first. You better target the right patients with the best treatment in the first line. So that's more of the thinking that we're trying to develop, and that's really work in development. It's really work in progress. But I'd like to demonstrate that with work that Amanda has been doing in prostate cancer. So Amanda's been working with Dan Tran and Aisha on the EPAT database. That's a large real-world database on metastatic prostate cancer, castration-resistant prostate cancer. And we've been looking into the different sequences, and we're specifically in the sequence of docetaxel and anti-hormone therapy, ARTA. So that's either enzalutamide or abiraterone. And this is the breakdown of the cohort. So this is the total number of patients, first line option, docetaxel or anti-hormonal, and second line option. So following docetaxel, the second line potentially could be enzalutamide, abiraterone. So it's important to know that on the PBS in Australia, the first line treatment of choice is docetaxel, unless patients can't tolerate this. There's several reasons why you could start with enzalutamide, abiraterone in the first line. But for some reason, you might think, well, there might be evidence that it's better to start with the anti-hormonal therapy first, say enzalutamide and abiraterone in the first line. So we can look into those two sequences, and there's some data. It's not a huge data set, but it's definitely some interesting data. And that's what Amanda did with her team, looking into the two sequences. So we've got two sequences: first anti-hormonal followed by docetaxel, or we've got the sequence docetaxel followed by enzalutamide, abiraterone in the second line. And the first line here, this is the two options. So the green is those patients on either enzalutamide or abiraterone, and the purple it's on the docetaxel. And we measured the time to treatment failure, because that's the indication for progressing to the next line of treatment. So you see in the first line, most treatments, so the treatment failure, if you're on abiraterone or enzalutamide, is up to 1,500 days. It's way longer than in your docetaxel in the first line. It has to be said though that your docetaxel group usually is a better group of patients, a better prognosis, because they're less affected and can tolerate docetaxel. So that's the confounding by indication that's in the data set anyway that we have to acknowledge. But in the second line, you see the tolerance to enzalutamide abiraterone in the second line is also bigger. So that's the two different lines you can look into that. You can also combine the two in terms of the time to treatment failure, but I would particularly look into the cost, because I think that's for us at the moment the interesting piece, because we looked into the total cost of the treatment sequences, the ARDA docetaxel sequence and the other sequence here. And you see on average, or the mean cost of the two sequences is quite the same. That's explained because the more expensive drugs, enzalutamide abiraterone, are there for a long time. So time to treatment failure is up to 1,500 days, whether you use it in the first or the second line. So the total cost of the sequences really doesn't make that much of a difference. And that might be an argument for taking your first drug your best drug first, and not wait with your best drug after you've done the docetaxel, which is the standard of care, first line drug. So that's how you do overall costing across the two sequences. So the other thing, and that's really the new project we were awarded in the MRF scheme just a month ago. This is what we call the PRIMCAT project. It's the population health economic impact. So in the previous slide with the prostate cancer, I've shown the total cost of the treatment sequences might be not too different. This takes one step further. So in PRIMCAT, there's a concern from the Department of Health and regulatory agencies that if you approve a drug, you want to know how many patients actually will be using that specific drug. And whether you use it in the first line, the second line, the third line, you want to know the percentage of patients eligible for that specific treatment, because then you can make an overall budget impact calculation of that treatment. And if you can reduce that uncertainty, it's more likely you get that approval. So this is just an indication. So this is the idea of the PRIMCAT project in a nutshell. Is we come up with the incidence for those cancers in Australia. So there's 3 cancers that we look into: lung cancer, colorectal cancer, and melanoma. And we look into 2 pan-cancer mutations, NTRK and MSI. But this is just an example based on the non-small cell lung cancer. So we take the incidence of the lung cancer, an annual incidence, and we can, from that incidence, we can molecularly test it. So we can apply to panel, and we can identify specific mutations. So let's take the EGFR mutation. About 15% of the patients here has the EGFR in a lung cancer patient is EGFR positive. Means you might be eligible for EGFR TKI inhibitors. So that's the idea. So this is the prevalence of that mutation and the cancer incidence would potentially identify the eligible population. So they will be prescribed first-line treatment, gevatinib, for instance, and then erlotinib in the second line and osimertinib in the third line. That might be a typical treatment sequence for those patients. But you want to know if those patients receive that in the first line, you want to know how many patients of those, so we've got the lung cancer incidence, we've got the EGFR mutations, you want to know how many actually will receive that first line gevatinib treatment in the real world. So we have to estimate the eligible numbers of patients in the first line, but we also have to estimate the percentage that we receive that drug. And if we know the percentage that receives the drug, we can estimate the impact of that specific approval on the PBS and MBS. The same would apply for erlotinib in the second line and osimertinib. I think that's all straightforward, and we can do that based on real world data that we have. But it's going to get a little bit more complicated because we can expect all kinds of dynamic changes. We can, I said, with the treatment sequence, and we can expect that osimertinib, which is approved as a second line drug or a third line drug, might be used as a first line at some point. There will be an upfront, there will be a change in how it is going to be used. So you want to anticipate on the changes in how those drugs are best to be used. And if you would use that osimertinib in the first line, this will change the total numbers. This probably won't change your eligibility, but it probably will change your percentage that receive that drug. So that's one of the challenges. But also, if that's an upfront treatment here in the first line, what will happen to the third line here? Is there another alternative? Will there be more treatments available? And I just had a check with the FDA. That's what the month May was a unique month. But just for lung cancer in the FDA in May, there were 7 new drugs approved for specific indication for lung cancer. That's a significant number of new approvals. This is usually not the 7. Usually it's 1 or 2 for each time. But that's a very significant number. So one part of the project is really to map those treatment pathways with real data, estimate the numbers of patients eligible for the treatment, and to estimate the number that actually receive the treatment, but also do horizon scanning about which drugs will likely be available in the next 5 years, and how would these drugs be used in the current treatment pathways. So that's the other piece of work and that's really the challenging part. So I'm very pleased. This is a very interesting project for us in multiple ways. It's a great consortium that we work with, and Sally Pearson in New South Wales, and Yuting Zhang from the Melbourne Institute, Adam Elshuk from Sydney, Peter Gibbs in Walter Eliza Health Institute, quite a few colleagues from Peter Mac, lung cancer, melanoma, and from pathology, Stephen Fox for pan cancer with Jayesh Desai, and University of South Australia. So it's a very interesting consortium to build on, and that could be a significant amount of work. So this is where our expertise and developments in the real world data space is very handy. So just to show, because we have opted for the 3 cancers that we have experience with: colorectal cancer, lung cancer, and melanoma. And for all 3 cancers, and this is all based on PRIMCAT, we've got the real world data. We've got the treatment sequences, the first line, second line, third line treatments for melanoma based on the MRV. We've got it for colorectal cancer and for lung cancer. And this is a great team that I'm from our department working on PRIMCAT. So Fanny working on the treatment sequencing, extrapolating treatment sequences to the population level. Koen is doing the modeling in terms of predicting health impact. Sophie is working with Jayesh and with Stephen Fox on the pan-cancer mutations based on complex genomic sequencing, predicting histology independent drugs. And Jen is working on the melanoma case with Grant MacArthur. And then Karen finally is as the just recently graduated Master of Public Health, working on the repository for the epidemiological estimates, but also the project management of this very exciting new project. So that's PRIMCAT. And just to summarize, that's already been published. First line, second line treatment, third line treatments. This is the percentage of our patients actually receive the treatment. So that's the estimates that we already have from those data. And you see that there's a significant number receiving a first line, but there's quite a bit of difference in the third line here. There's in particular, in some of the cancer streams, there's, I won't say under treatment there, but the treatment opportunity is really in the first and the second line. All right, so it's not just about the treatment sequence. And the second part really is about the diagnostics. And as you know, this is just a case that Marty is working on with Piers Blombury and David Westerman on blood cancers, where we use chronic lymphatic leukemia, and specifically looking to molecular tests. The PBS actually lists the drugs is for the drug listing. The MBS codes is really listing the diagnostic test, which is a campaign diagnosed to that specific indication for that specific drug. So in this case, the MBS item 73343, that's a very specific FISH test for treatment in a second line with, for instance, ibrutinib or venetoclax. So that's a very specific test done for that specific line of treatment. But there are some people that don't respond to chemoimmunotherapy in the first line. So you might think of doing a more comprehensive gene panel in the first line, because there's a significant number of people that don't respond to the standard of care chemoimmunotherapy in the first line. And you might identify those patients, for instance, with P53 mutations, IGHV mutations. So the question that Maarten is going to address here really is whether we could better do an upfront test of all kinds of mutations to stratify patients for the right treatment in the first line, rather than just wait for a second line for a relapse or refractory disease, test for 17p deletion to indicate for those treatments. So that's one way of looking to how can we optimize diagnostic testing to indicate specific treatments in specific lines of treatment. That's the same. So that listing of MBS item numbers for specific treatments, it's very similar for, this is the case of lung cancer, where I've identified all the different MBS item numbers relevant for lung cancer. You see there's a cascade of different tests that you can do and are indicated for a specific treatment. So one of the questions, and that's a discussion that we've had before multiple times, whether we could better do a panel, a targeted gene panel, or even a whole genome to indicate which treatments might be the best treatments for those patients. So thinking about efficiency of diagnostic testing. And this is also an example where we use real-world data. And this is probably a slide that some of you have seen before, where we've mined a large data set of tests, actual pathology tests done in the lab for lung cancer, stage 3-4 lung cancer patients. And you see that the sequence of tests that were done. And we can do that, and we can look into the specific mutations that is tested for, and we can for every individual patient, we can determine which tests have been performed. So this is for, in that single cohort, all the tests that were used for that specific patient. So you see there's 97% unique combinations of tests being performed. So that's one way you can look into that real world data. The other thing that we are trying to do is, suppose you would replace all those tests for a whole genome test. Would that be more efficient? Would it be costly? Or would it be too expensive? So that's what we've done here. So if you take, this is the distribution of the costs of the molecular testing for lung cancer. So it costs per patient with an average about 1,500 euros, but with a range up to 6,000 euros. This is the Netherlands data. So if you know this is the distribution, and you know the cost of taking a whole genome, at the current cost, it's about 4,000 euros, 4,700 euros. So that means that there's only a small proportion in which a whole genome might be more efficient compared to the sequential test, cascade of tests that we currently do. But if the prices drop up to 2,000 euros for a whole genome, you see there, it might be much more cost efficient to do a whole genome rather than a cascade of tests. In particular, think about new mutation, new molecular targets that will be developed and available in the guidelines. So this is one way to look into what's the optimal pathway and the efficiency of diagnostic testing. And in that respect, I'm particularly very pleased with all the leadership and support from the UMCCR in establishing the collaboration with Illumina, and very exciting for us to be involved in that program with a specific package of work on health economics and health services. And in that specific part of work, which will commence hopefully very soon, there's two very specific projects that we will start working on. One is on liquid biopsies for cancer management, and the second one is a follow-up on the work that Marty's been doing on CLL. And then we work with several people at Peter Mac and UMCCR on the potential of whole genome sequencing in acute lymphatic leukemia. So that's very specific work to be done in the genomics and diagnostic space. All right, I've got a few, I'm running a little bit over time. I just wanted to share a few more slides on the work that we do in health services and COVID. And I think this is all I think familiar to you, that in recent times, since the start of COVID, since the first lockdown, we've seen a decline in cancer incidences worldwide. And this is granular data from the Netherlands, but this is confirmed from the Victorian Cancer Registry, there's a decline up to 37% in breast cancer diagnosis. So there's a concern because of declining cancer incidence. It may mean there's a less of referral to hospitals, and it might create a backlog of patients being requiring care. So that's a concern that we've looked into, whether this decline in cancer incidences will, I'm switching to the next slide, will actually lead to a delay in time to treatment initiation. And if that delay in time to treatment initiation is correlated to poorer survival outcomes. So that's the key interest. So if you want to know more about time to treatment initiation, you can break it down into different components. You can look into the GP, the primary care component, with the diagnostic delays. Visit your GP, from GP to hospital, in-hospital delays with the diagnostic testing. And then there's a section on the treatment delay. So that's where you can map the total pathway to treatment. So that's where we started to do some work. So then we had a bit of a discussion with quite a few experts. Say, well, if you expect 3 months of delay, that shouldn't be too much of a problem for cancer. Many cancers can wait for 2 to 3 months. That's not that critical. It might be a bit different if it's going to be 6 months, which might likely to happen in the second lockdown that we're currently in. But that was the initial discussion that we had. But then we did a bit of hypothetical modeling. So, okay, if we assume there's a bit of decline in incidence, and there's a decline in the capacity to see those patients, what would that mean for seeing those patients in the backlog of patients, and what will it mean for cancer referrals to hospitals? So this is just to illustrate. So this is the normal capacity, 100% in a hospital. Any hospital can take 100% capacity. And this is the normal numbers of patients. The green lines here, that's the normal patients being referred to the hospital. And you can see everyone can be seen within the normal capacity constraints. So that means there's no one really waiting for care, for delivery of care. So there's no waiting list. So that's the normal pre-COVID stage. So if we would say a 2-month delay for 30% of the patients, so we've seen a decline in cancer incidence, patients not seeing their GP. 30% of the patients have a delay seeing a GP. So there's less demand here. There's less demand, but that demand, creates the backlog, and those patients will be seen by the hospital. And then you go way over capacity. So in that case, there will be a waiting list because you can't see all the patients with that 100% capacity. And it will take some time to work your way through until you receive that plateau and can see everyone within that capacity constraints. So that's going to be about 2.5 months. So that's all fine. But it's going to be a little bit different if there's a capacity issue with the social distancing in the hospital. If we can only restore 90% capacity here, you see that even a 2-month delay for 30% of the patients and a 90% capacity post-COVID could lead to first a delay of 4.5 months at least, but it also creates a waiting list because we can't see the current demand with that 90% capacity. So that's an illustration of the issue we're talking about. And that's what we've done, and that's really the credits go to Koen doing the modeling on that specific piece. So can we estimate whether there's a delay in referral to hospital, and whether that delay in referral to hospital means there will be a stage progression and poorer outcomes? So we did that using aggregate data. So we used data from the cancer registry, stage of diagnosis, and we know we can extrapolate survival based on stage information, and we can build a model based on aggregate level data. And then ideally you want to get additional data sets so you can update your model to get precise estimates. So for instance, cancer incidence available right now for Victoria can be used to update your model. That's basically what we've done. And the principle is what we call the stage progression model, stage shift model. And that's based on the stage distribution. So if you would see, this is a normal stage distribution in the base case for one cancer, 1A, B, C to 4. And, for every stage, you can extrapolate survival And that means for every stage, you can compute the number of, estimate the number of patients still alive after 5 years, which gives you about 39% of the patients based on your current stage distribution at diagnosis. If you would screen for lung cancer, you expect, of course, less severe diagnoses. So there will be less patients diagnosed at stage 4. So there's an improvement in terms of your overall survival. So it's more diagnosed at stage 1. That's the stage shift in the positive way. But now if we think about delays, we think that there will be a stage progression. The delay will result in a stage progression. So that means patient will be diagnosed as a more severe stage. And that's what we try to simulate here. And we try to relate that stage progression to the delays that people incur. So in this case, we can reduce we expect a reduction in the survival, the numbers of patients surviving the 5 years to 28.5%. So that's basically what we try to do. And on that modeling page, we just looked into 4 specific cancer streams where we estimate the total, got the total cancer incidence from cancer registry data. We got the percentage of stage 1 disease. So we only modeled stage 1, so it's very, very conservative in terms of the extrapolation. We estimate the numbers of patients that progress for a 3-month delay and for a 6-month delay. And then we compute the excess mortality. So in this was done in April, early April. And from that experiences, and it's only the 2020 incident case. We don't look into care interruptions for prevalent cases, patients already being treated for their cancer. So these are only the new cases. So in that case, we expect the total excess mortality to be up to 500 across Australia for 4 cancers only, and for 45 million excess cost for 4 cancers. And that's pretty much of a conservative estimate. So that's something where we ideally want to have population level data to update that model. The other thing that I'd like to acknowledge is the work that Grace has been doing. Grace is a medical oncologist in our group working with Ben on a survey. So what have we seen actually in care provision? What has changed in clinical management? That's a survey of about 450 people across the world through ESMO in Europe and through COSA in Australia. And you see, well, there definitely are differences in terms of people that have seen patients with COVID, but most importantly, we can use the survey to identify what changes we observe. So many people see a change in management, and there's a very significant increase in the number of telehealth consultations. There's some more details in the survey that we'll be using to analyze population level data, because we expect changes in chemotherapy prescription. We expect differences in immunotherapy because of COVID management, and that definitely will impact survival outcomes. So that's all work to be done by Grace and team in the near future, based on that survey that she's done, but also based on population level data that we can access to. I'm coming to the end, so I want to go back. So this is the magic whiteboard. It's still full of ideas, and I think I'm very pleased and excited with the progress that we've made and with the plans that we've laid down in September 2018. I think we're very excited, still very excited, and full in progress and full in development. So I'm really keen to maybe present in another 2 years about progress for the next 2 years. Anyway, this is the key risk stratified health services that we wanted to develop: health economics, liquid biopsy, genomics, and precision oncology. That's really a big piece of work. And then the second big, using clinical registries and linked data, and risk stratified health services, particularly follow-up work that we just started with Michael Gifford and Nina Afshar in our group. I'd like to conclude with just acknowledging a few people that I didn't mention in my talk. Very important for me: Olivia, managing the whole group; Rob, Ricardo, working on patient preferences for prostate cancer; Nina just joined our group, and Julia. And then thanks very much for all the staff, and particularly also for UMCCR staff and Melbourne School Population and Global Health for their leadership in these difficult times. Thank you very much.
Fantastic. Thank you very much there, Maarten, for a great presentation. I would invite all you attendees that if you have questions, feel free to pop them into the windows below, and then we can start to work through some of those. Maarten, I think you showed quite really a broad range of projects that you've got underway there, and I think there's some really quite profound insights coming from that, but also I guess I see that as a way to start to kick off a lot of other questions or things that can be pursued. I guess in order for me to understand this space a little better, when we have a look at the cancers that you're driving in terms of the MRFF proposal and your others, you're working with cancers like lung, colorectal, melanoma. Those cancers are the most prevalent in our communities, and we also have centres of excellence here. But I wondered if you could make a comment about the importance of I guess, power or scale to the type of work that you do, trying to understand how will these approaches, I guess, in my head, can the same approaches be as useful for rarer cancers or for many of the cancers that are poorer outcome? They're really not very common. So I'm just trying to understand how important power and data is for you.
Yeah, thanks, Sean. That's a great comment. I think that's absolutely right. So we've prioritized working on those cancers for two reasons mainly, because some of the experience I had previously, so that was a bit of my experience in those cancers. But the second reason was availability of data, because for those cancers we have very comprehensive data sets that were managed very well, and I found it relatively easy to build a collaboration with those people and the data custodians to do some of the work that we've been doing, because it really complements the work that they already do, and that's a great buy-in into their programs. I think for the next period, scope is critical. If you see the world competition in this space, the data sets that people working on are multiple sizes, bigger than these data sets of 4,000 patients. So I think that's where you want to end up, and not just because you want to do more studies on mapping care pathway, because that's pretty much Australia focused. That's where you need the Australian data. But if you want to do some work on dynamic treatment sequencing, for instance, understanding the sequences and getting rid of confounding or addressing confounding in those data sets, you need scale. The other thing is in the genomic space, because that's where my key interest also will be. If we can drive specific treatment decisions based on genomic aberrations, and that requires really skill in linking clinical registries, not just the single fish and tests that were done, but to a comprehensive gene panel to identify drivers, but also to routinely monitor those patients. For instance, the liquid biopsy space, to routinely monitor those patients with liquid biopsy to see if there's progression that will inform treatment switches. And that requires a different level of data and requirements to do the work that we wanted to do.
Okay, actually, I didn't think about the fact that registries are absolutely essential to the work that you're driving there. So the cancers you're working with there are not just common, but they actually have fantastic registries behind them. Just following on quickly, I can see we just had a question pop up from the audience, but I might just follow on that you've talked there about how there are much larger efforts going on internationally. Could you make a comment about how the importance, and it's quite clear that you're working internationally with a lot of different groups, the importance of how we validate or replicate findings that we see here within our system albeit the healthcare systems can be different elsewhere. So I would have figured that with any of this, once you find a trend and you think you've found a correlation, you think there's something significant there, how big is the effort to try to then validate that in other systems?
I think every system is unique, and I'm not sure you can translate the Australian experiences to another country and vice versa. So that doesn't make sense. The whole payment system is different. The incentives are very different. So you have to establish a local Australia registry specific for Australia, as long as it's about health services and health systems. I think in terms of research more on the molecular mechanisms and the treatment sequencing, that's less dependent on the system that you're in, and that's where I think the skill comes in as a key issue. Where you can potentially, so some of the work that we do has a training cohort. So some of the machine learning methods on prediction models, we can use a training cohort. We can establish a training cohort and a validation cohort. So you might think of having a training cohort based on a very large registry somewhere else, and then use that to validate it on a local Australian data set. So that's where I'm thinking it might be an opportunity.
Yeah, I thought standing on those shoulders, and then you can use that to test hypotheses or train on that, and then try to validate in our system would be an interesting way to go. Yeah. I guess another. Sorry.
Maybe just no. Sorry, I was just thinking about the rare cancers as a follow-up on that initial question. I think if there's one cancer in which you need economies of scale, it's the rare cancers, and that's why I've seen a lot of push from patient organizations, from societies to really establish one big registry, one population level registry, because there's no way you can do research on those cancers as an individual institution. So that's where you really have the economies of scale. And I think data sharing, that's the whole holy grail, is really contributing data, sharing data, and really working together.
Yeah, absolutely. You're going to be waiting a long time for just standard random clinical trials to assist those rare cancer patients. It's not going to happen. I think one of the other things that really struck me with the graphs you're showing there of the complexity of treatment for the likes of colorectal. It's interesting. I wouldn't have thought that the care paths would have been so complex. The decisions that are being made there and the number of choices that are available seem to be enormous. I'm just curious as to, and in terms of the data that you're collecting there, you've got information about the path of patients having treatment A, B, or C, and what that treatment was at a given line. As we move towards this EMR approach, clearly there's decisions being made on those paths. Hopefully they're not too random. Are we going to be anywhere near in the near future to be able to try to extract some of the rules that are instructing those paths? Or are we really still at that stage of just being able to more accurately model that and then think about changing sequences and other efficiencies within the system?
Yeah, I think it's very exciting that we're just about to launch the EMR. And what I've seen and the discussion that we've had, I think the great opportunity for the EMR is really to extract more clinical management information, administrative data to map the care pathways. That's something which you can do. It's probably more complex to use the EMR to get sufficient granular data to understand why specific decisions have been made, or why why there's progression, or why there's a switch to second line, third line treatment. So that granular data is not going to be available in the EMR, and you probably still need several data sets linked to your EMR to be able to address those questions to a large extent. So that's why I'm keen on linking also pharmacy data. Pharmacy will be part of the EMR, but genomics data and the pathology data to inform that decision. At the moment, we're trying to use administered data, because one of the key questions for us is using administered data to identify patients on immunotherapy with adverse events, so immunotherapy related adverse events. Because that if there's a grade 2 or 3, it might progress and you might discontinue treatment or change it. And identifying those patients early on might improve their overall prognosis and survival. So the question is, can we identify immunotherapy-related toxicities from an EMR using admin data? Or do we need to collect additional data sets, PRO data, self-report data? So that's a study that we're trying to establish in the next year or so.
Yeah, look, that's a very exciting application. Well, a specific question would be important to get an application for. I guess it just strikes me the knowledge base behind the combined services to see a colorectal patient move through those numbers of choices and decisions being made from first to third line therapy is really quite a tangled web. Remarkable. All right, I think we're actually coming up to time. So with that, I would like to thank Maarten again for a great presentation.